should be on, were on at home, for some reason doesn't get picked up, doesn't get orders, can have a bad outcome for them. Sometimes there's duplication of meds, right, so we need to pick that up too. So every time there's a transition of care, there's a risk for error, which is why we do med reconciliation. That's the method behind madness. We list the patient's home meds. We want everything. We want what they're prescribed. We want what they take over the counter. So you're going to ask them, if you have a headache, do you take Tylenol? If you have joint pain, are you using anything over the counter? NSAIDs for your joint pain. Are you using any herbal or complementary medicines? We document it all. When the patient comes into the ED, it's either pharmacy and or nursing that does the med reconciliation. Typically, once they get to their unit of care, it'll be the nurse doing the reconciliation. So what's our responsibility in this whole process? Is to compare the two lists and see if there's an omission of an order. The patient was on a beta blocker at home, but it wasn't ordered. So we need to notify the healthcare provider. Maybe there's a reason it wasn't ordered. Maybe the patient's, I don't know, systolic BP was low, and the healthcare provider wanted to hold it. That's fine, but we still have an obligation to follow up. So we're looking for omissions from when we're comparing the two lists. We're looking for omissions and we're looking for any duplications. We want to be sure that they're getting whatever home meds they should be getting. Because the issue here is polypharmacy. People go to multiple providers, people go to multiple pharmacies, and we have problems with drug interactions. So med reconciliation, again, prescribed, herbal, and over-the-counter stuff. It's all of it. We do it again to keep patients safe in our healthcare environment. And it's always done at transition points in service. So if you would kindly pull out your time management PowerPoint. Teamwork. This one here, I'll pull it up so you can see the first slide. Teamwork and collaboration. Teamwork and collaboration. All right. So everything we're talking about today is about keeping people safe in our healthcare environment. One of the competencies for every member of the healthcare team is that we collaborate, we all engage in active participation. We have interprofessional meetings to do this, we have safety huddles to do this. But if you hear nothing else about teamwork and collaboration, know that it's about understanding what every member on the team does, what their expertise is, how they fit into the pieces of the puzzle. As the nurse, you have the most face time with the patient, correct? You're the one, everyone else comes in for 10 or 15 minutes, and then they leave. Their visits are episodic, PT, OT, whoever working with the patient. But you, the nurse, have the most face time with the patient. So your contributions to the plan of care are valuable because you get to meet the families, you get to know the significant others, and you spend the most time with the patient. So again, the patient is the center of care, as we've said repeatedly. The cues and competencies involve teamwork and collaboration because we know if we understand each other, every member of the team, we understand what our contribution is, we work better together, and that only has better outcomes for patients. We use evidence-based practice, just meaning everything we do is based in research. Quality improvement, that I'm going to talk about next. Safety, always on the forefront. And we use informatics for those of you who like, and I don't know that anyone does, but those of you who like research, who like crunching numbers, that's another role if that's your thing for a nursing role. There's actually a nurse informatics person at each healthcare institution. And they're responsible for looking at data that we're collecting on safety in the hospital and determining what the data is really telling us. So the concept of collaboration, again, is an expectation. Most of our, here at Naugatuck Valley, we have a respiratory therapy program. We have a physical therapist assistant program. and we have a rad tech program in addition, obviously, to our nursing program. And in the first year, you worked with, I want to say you worked with the PTA students in the mobility lab. Is that correct? You still do that, or?
No.
Oh, you didn't? Okay, they used to do it in the past. I think in the spring you will be working with respiratory and with the rad tech students on a joint simulation. So you get to learn, even while you're in school, what the other disciplines do and don't do, what the responsibilities of the team are. So the concept of collaboration is interprofessional, and successful collaboration requires that we have good communication skills, that we have an atmosphere of mutual respect for one another. We don't have to like each other, ever, but we have to be kind to one another, and we have to be respectful to one another. We need to value one another's roles and always work to establish that atmosphere of mutual respect. In terms of the member of the team, you obviously are a very important member of the team. The most important member of the team is the patient, who is at the center of care. As the nurse, you again are delegating to your unlicensed personnel. In terms of your nursing plan of care, it's unlikely that the physician will read your nursing plan of care, and I don't mean that in any disrespectful way. It's always more important for us in interprofessional meetings to openly communicate with our physician colleagues about what patient concerns are, what our patient and or their family concerns are. So that's understanding, the educational background of our team members too. Our case managers tend to be RNs, another interesting role. If you like coordinating home care or you like community nursing, case management is a really interesting role. Maybe you can get time to spend with a case manager while you're at clinical at some point. Dietitian, registered dietitian, they're generally prepared at the master's level. That's who I'm reaching to for anyone who is struggling with, we're struggling to meet their nutritional needs. I'm definitely going to consult and work with my registered dietitian. Information technology expert in most places is a nurse. Generally, it's somebody with an MSN, with an advanced degree. Again, they're crunching all the numbers. They're looking at data from patient surveys. They're looking at the data of the number of falls in the hospital, and they're analyzing it to determine what we're doing wrong or right. The occupational therapist, as we've said before, is an individual that helps patients reestablish independent ADL, so they come up with equipment to help people be independent again. Pharmacist is doctorally prepared. Don't ever hesitate. If you go to Lexicon or whatever your drug source is, you have to hang or mix a med you've never hung or given before, and your references are vague or you don't understand what the reference is telling you, don't ever hesitate to pick up the phone and call pharmacy. This is their wheelhouse, and they're happy to help you. I have called pharmacy a million times in my 37 years as a nurse, so I don't ever want you to feel uneasy about doing that. They are the experts. The physician, of course, that's extensive education and residency. And the physician assistant, I can't believe I didn't put APRN on the slide. I meant to put /APRN. They're mid-level providers. They're prepared at either the master's or doctoral level. They have prescriptive authority. The respiratory therapist is typically like us, they're prepared at the associate degree level. But again, who I'm going to reach for if I'm struggling with equipment, like, all right, I tried the bench mask, what do I do now? Or I've got the non-breather, can you come and help me with this patient kind of thing? That's who you're reaching for. The social worker is the person who's helping us with those. Remember Maslow's hierarchy of needs, that bottom one, the physiologic, the basic needs. Shelter was one of those needs. And so when you have someone who's homeless, it's your social worker who we're going to pull in that situation. I would say too, it's not on the slide, but I would add it, the patient and family are welcome to attend these interprofessional meetings. Hard to coordinate, but we do coordinate it, and they can attend, and they should attend. Particularly if you're dealing with someone who, if the patient's been involved in a trauma, and the family's got to make all these big decisions, you want the entire team to meet with them. I didn't put patients to be a part of in their families, their caregivers, to be a part of the process, to have a voice in their plan of care. Okay. So I talked about mutual respect and trust, effective communication skills, past this, competencies. Miscommunication is one of the frequent root causes of a sentinel event. A sentinel event, again, is an event that occurs to a patient that results in either patient death or permanent disability. That disability can be physical or psychological. Psychological might be a little harder to prove, but that is what a sentinel event is. If a sentinel event occurs in our healthcare settings, we are required, because hospitals take money, right? We get money, we get funding from the federal government. We also get funding from our state, our local government. And because we accept that funding, we are required by law, as well we should be, to report sentinel events. And that is so that Joint Commission, who accredits us, can look at what the sentinel events were on any given year, and that's what they determine. That's how they figure out what the patient safety goals are going to be for each year. For instance, this year, 2022. It's based on what's gone down in our agencies over the course of the year. Expert collaboration, being accountable for your communication. Each member is sensitive to the differences in communication styles of other members of the team. Team-centered communication. Effective communication only occurs when we understand the value of somebody else's role. We understand what they do. And oftentimes, I think nurses have a good understanding of what all members of the team do. I think some of the other members of the team don't always understand us. Part of the problem with that is a nurse is not a nurse necessarily. We have so many layers of education, it's really confusing to people. So, we could be an LPN, we could be an associate degree RN, we could be a diploma, although the diploma schools are mostly closed now, but diploma schools were 3 years. We could have a BSN, 4 years of education, right? We can have an MSN or a doctoral degree with, 5, 6 or more years of education. So it's very confusing, and people lump us all together, and it's not clear to other members of the team exactly what we do and what our educational process is. So we have to help them understand it better. Don't worry about the right-hand side of the slide. You can put an X through it. The change of shift report is, again, very important. Teamwork, collaboration, keeping the patient safe. This is when you do your initial survey. It should be done at the bedside. You're looking at whatever's running. You're noticing if the patient has oxygen in their nose. You're noticing if they have lines. You're noticing how they're breathing. You're noticing their color. So it's all of that initial information. In terms of decision making, we have to determine which discipline is best able to address a patient's needs. And so again, as we said earlier, if it's a nutritional need, it's a registered dietitian. If it's a psychosocial need, it's either your case manager or your social worker. I wouldn't be able to help somebody find housing or a shelter, get a bed in a shelter. I mean, that's beyond our scope, right? As nurses, we don't do that. That's not our wheelhouse. Nurses are often able to help the team identify priorities because, again, we're with the patient the most. And benefits of interprofessional collaboration, why we do it, why we talk about it, is because we know it keeps patients safe and it improves their quality of care. When we are all talking to each other, it only has good outcomes for the patient. And if your patient has a concern about the plan of care, talk it through with them. We can't leave them out of the loop. The patient says, I'm glad that's your plan of care, but I'm not doing it. That's a problem, right? We have to say, all right, let's talk about it. We got to negotiate a little bit about what they are and are not willing to do. All right, so if you can pull out your quality improvement handout. story that I embedded and included in here. If you have any trouble opening the video, please let me know and I will repost. Josie's story is an outcome where a child died as a result of the nursing staff in particular, but medical staff too, but the nursing in particular not paying attention to cues that the child was decompensating and not listening to the mother. And what will impress you most out of this story, it's horrifying, but what will impress you most about this story and the other video and the previous PowerPoint about Lewis who died, he was I think 17, is that both mothers in these cases advocated for their child, but both of them took the tragedy and took political action and did something about it to make sure that no one else loses a child, which I think is pretty remarkable. Okay, so why we do quality improvement? Because of that seminal study that was done back in 2000, error is human. We are humans, we do make mistakes, but how do we minimize those mistakes in hospitals? And that's really what quality improvement is about. It's looking at trends, it's looking at, if we have, for instance, we're noticing that there's more patient falls on one unit than another unit, what factors might you consider? Somebody said it over here. Say it louder. Staffing. Yeah, absolutely staffing. Maybe that unit is not as well staffed as the others. Other reasons that we may be seeing trends in either more med errors or more patient falls or adverse outcomes for patients may have to do with staffing. For sure, the literature is clear on that. Poor staffing leads to adverse outcomes for patients. It might be the equipment failure stuff we talked about earlier. The nurses don't have functional equipment or enough equipment to do the job and do it right. Maybe we've got the equipment, but we've never been properly trained on how to use the equipment correctly. Big problem, right? That's a big problem. Maybe we have a false protocol in place, but nurses are inconsistently following it. Everyone's kind of doing their own thing. And I can tell you in a court of law, if you're a nurse called in for anything, the first thing they ask is, did you follow your agency policy and protocols? And if you did not, you're in trouble. So the message here and now is always follow your agency protocols. You will never get into trouble. Even if the protocol resulted in an adverse outcome, you are still following your agency protocol. Okay, so quality improvement, again, it's more at a systems level. Like we've talked to this point about how you keep the patient safe at a microcosm level, how you keep the patient safe at the bedside, but this is really sort of the bird's eye view, the big picture view of how the organization, how the hospital has a role in keeping patients safe, and sort of where we fit into that picture. So we do quality management. It says evaluation, lower right-hand corner, evaluation of what we're evaluating our processes. We're looking at how well we're doing taking care of patients. We're taking that whole hard look at our practice and saying, what are we doing well and what do we need to do better? And we're always going to compare ourselves to the leaders in the industry, you know, to the people who are doing it really well, who are doing it best. That's the benchmark. That's the standard that we want to get to. I included resources for you in terms of the national federal initiatives, U.S. Department of Health, the AMA. These are all just databases, the Joint Commission. These are all agencies that protect patient safety. You're not going to be tested on them. They're just here if you need them as a reference.
The slide isn't matching on the board.
Oh, thank you. You know what? It's not. Hold on. I can do that. Thank
When are you guys working? When are you working Saturday? What about tomorrow? Oh, you work Monday too. I texted my manager that she can use that
Oh, when you print these, you just go like on the PowerPoint and hit print, and that's how it comes out.
All right. So the quality improvement process, we analyze protocols that we are using in our hospitals to keep our patients safe. We are doing interprofessional assessments, again, to improve the quality of care. And we're determining by using audits if what we're doing is indeed working. Utilization and review is analyzing, again, the data and looking at fiscal resources. Are we overusing or underusing resources available to us? The outcomes of the quality improvement process is that we implement evidence-based practice systems. Quality goes hand in hand with research, with evidence-based practice, which is why there's a piece in the, and I'm going to talk about it in a minute, in the quality improvement projects that your clinical groups are going to work on. There's a piece where you pull an article, an evidence-based article from the literature as part of that project. It's just to get you familiar with research and the fact that everything we do in the hospital is based in research. Guides our decision-making, incorporates better, efficient clinical management of our teams and our patients and our care. The benchmarking, again, is looking at how we perform compared to other agencies in and around us. We're always comparing ourselves to the leaders, as I said a moment ago. Standards of care, remember, standards of care is always what for us, any reasonable RN would do in that situation. So the failure to rescue case, the girl in the ED, did that nurse, do you think, and I know we only heard one side of it, but based on what we heard, based on what we have in front of us, do we think the nurse followed the standard of care? No. No, right? You haven't even learned neuro yet, but what did you hear? What were the cues you heard that kind of grabbed your attention?
Pupils, eye movement.
Dilated pupils, the abnormal eye movements, changes in reflexes, her level of consciousness, right? You haven't even learned it yet if you put those pieces together. So any reasonable nurse that has somebody decompensating neurologically is going to intervene. When a sentinel event occurs, what is a sentinel event again? Death. It's an injury or an error. It can be a med error too, or an injury or a fall that happens in our environment that results in death, permanent disability, and that disability can be physical or psychological. We have to report sentinel events to the Joint Commission, who accredits us. So an example of this would be a few years back, Waterbury Hospital had an individual who came in with active suicide ideation. That individual was placed on suicide precautions, a watch. They had a policy and protocol in place. Unfortunately, somehow, some way, no one took his belt from him. And so he unfortunately carried out, the suicide. And obviously a sentinel event. The Joint Commission came in, and their first question to the hospital was, okay, what are you gonna do to make sure this never, ever happens again? Right? So what they had to do, and I think they were given 6 months, they had to come up with a new policy and protocol, so they had to go to the literature and make sure what they were doing before was indeed the most current best practices. So they had to go to the literature first, they had to do the deep dive. They had to then set up new policies and procedures to make sure there'd be no gaps, this would never happen again. But once you do that, you have to determine who's going to train the entire staff in the new policies and procedures. They had to spell all of this out for the Joint Commission. And then once you implement the new policies and procedures and you train your staff, you have to prove to them, the Joint Commission, that you you actually trained your staff. You have to have evidence of that. And so you have to think about who the point people are gonna be. You know, you have to bring in your nursing department of ed, your risk manager, and your quality improvement departments. The root cause analysis is when something really bad happens in our healthcare agencies, we have to sort of peel all the layers of the onion back and determine, go all the way back to the beginning and figure out where the ball got dropped. It's not about placing blame, it's not about pointing fingers, it's about trying to figure out where in the process the ball got dropped so we can put other processes in place that prevent it from happening again. So breach of care occurs when the nurse does something, either does something that should not have been done, it may be giving, the wrong med to the wrong patient, or does not do something that should have been done, and that's like a failure to rescue. Doesn't recognize those cues that the patient's decompensating. So the malpractice suits involving nurses always come down to a nurse didn't properly assess someone. I can't stress, I know I have, but I can't stress how important assessment is, and you doing your own assessment, not relying on someone else's. We can reduce risk by reporting problems to our supervisors and remaining current in our skills and education. We can do that with formal education, or we can do that just by reading more professional journals or attending workshops. Patient falls, because they often are things that cause sentinel events in our healthcare settings. Not every patient fall is a sentinel event, but there are enough patient falls that result in deaths of patients that we take fall precautions very seriously. So talk with me just briefly, you've been doing it since you've been in clinical. Talk with me about what you've done to prevent falls in your patients. So the bed alarm, cheer alarm, toileting them regularly because we know they fall trying to get out of bed to use the restroom. Lower the bed, make sure the bed's in low position, make sure they have what they need within reach.
Right, the call bell.
Call bell is within reach. Lighting, there's adequate lighting, they have proper footwear on, all of those things. And safety rounds, I heard somebody say safety rounds, I heard somebody say gate belt. That's correct. We should mobilize always with a gate belt. So the risk management process involves identification of risks that can lead to patient or staff injury. We look at our systems, always analyze the frequency and severity of past adverse events. So that's kind of like your team huddle, where we do the safety huddle in the morning. We all learn from one another's mistakes. The root cause analysis is just determining who, what, when, where, why, how did this happen? So the risk manager at your institution is going to interview every single person that was involved with the care of that patient in an effort to figure out if the system processes failed the patient. Or was it human error? Maybe somebody wasn't competent, but maybe somebody didn't get the education on the equipment they should have gotten to. So that's what root cause analysis is about, trying to figure out where it all went wrong. This is a Swiss cheese model of accident causation. And so it's unlikely if you were to take a slab of Swiss cheese, it's highly unlikely if you were to pick it up, you get holes that lined up all the way through, right? The stars would really have to align for that to happen. But what happens with sentinel events in healthcare settings and with meta errors is that the stars align in a bad way. And so if you take this from the back of the slide where it says hazards, let's say, for instance, that the physician writes an inappropriate medication order. It could be too high of a dose, it could be a med that the patient's allergic to, whatever. It's an inappropriate order for whatever reason. So they write the order, the pharmacist then, if you come up to this piece of Swiss cheese, the pharmacist fills the order and for whatever reason doesn't question it, right? So now there's another opportunity, there's another safeguard in place that gets bypassed. Now that the nurse on the unit, the charge nurse, verifies the order, and again, for whatever reason, doesn't question it, and then we as the bedside nurse go in, and actually we're the last point to one physically handing them the med, right? So we're the last hope for this patient getting the right med, which is why we're so neurotic about 3 checks and 6 rights of safe med administration. So when a med error occurs in this situation, we have to go all the way back to the resident. Was the resident overseen properly by the preceptor? You know, why didn't pharmacy question it? Is there a process we can put in place where, you know, the charge nurse, I don't know, maybe she was distracted, she was in the station, maybe we need to set up a separate area, a quiet area for her. And then finally, that final stop, us, why did we make that mistake? Why did we give that med that was inappropriate for the patient? So it's when all of those safeguards really fail us. Fail the patient, I should say, us too in the process. So the point of root cause analysis, again, it's not placing blame, it's not, you know, to embarrass or humiliate anyone, it's just to figure out what went wrong. Once we figure out what went wrong, then your risk manager is gonna come up with a plan to make sure it never happens again. And then they have to determine, you know, who they need to help carry out the plan to fix the policies or procedures that are in place. And they have to evaluate, did it work? Do we have fewer medication errors? Quality improvement process of reducing med errors, adverse drug events. Again, we do no harm. High alert meds are your anticoagulants, heparin in particular. So some agencies have, I actually like one of my students is at Danbury, and when they come on shift and get their handoff, the 2 nurses make sure the correct concentration of heparin is up and infusing at the correct rate. They walk through the protocol together. I think that's excellent. I think everybody should do that. Insulin is another high error. There are some agencies that require 2 nurses to check all insulins. The barcoding, we get into trouble as nurses, not us personally in the room. Nurses get into trouble when they do workarounds, when they bypass systems that are meant to keep patients safe and to protect your license too. So if a nurse is scanning a barcode off a piece of paper and not the patient's bracelet, you've completely bypassed all safety for that patient, right? We always have to barcode the patient. Every time we go in, and I say to the patients, listen, I know at this point, when you go in 3 times over the course of 8 hours to give meds, and every time you're saying, can you state your name and date of birth for us? They get sick of it, They want to, I say, do you want to just tattoo it on your head at this point? But I explain to them, listen, I know it's frustrating, but we're doing this to keep you safe. Every time we give a medication, we are obligated to do this to keep you safe.
I always say to the patient, if you ever forget it, it's on your wristband.
Yeah. I like that. And so it's just being consistent with what you've learned in school and carrying that into your nursing practice. I'm, again, a nurse for 37 years. I have never stopped doing 3 checks. Never, ever, not one med, one time. I always do 3 checks. And I always follow the 6 rights of safe med administration. And you will too. Because no nurse, you're all here because you want to help patients. No nurse gets up and says, I hope I go to work today and make an error. Nobody wants to make an error. It's embarrassing for nurses. And now we've got, the Redonda case where we have nurses that are criminally charged. So it's another world. Okay, so strategies, don't do any workarounds with the barcoding, with systems that are in place to keep your patients safe and your license safe. So medication error is, again, an error. Either it's given to the wrong patient at the wrong time, the wrong dose, maybe they've got an allergy. It happens, it can happen. When it happens, we look at the staffing. Is it because of staffing? When we're poorly staffed, we know there's greater risk for mistakes to be made. Is it, again, faulty equipment? Are there not enough scanners on the unit and people are doing workarounds instead of scanning the barcode on the patient bracelet? Is it a human resource problem? Is it a competency problem? Is the nursing staff not being trained appropriately to prevent med errors? So when an error happens, we do fill out an incident report. That is a separate form. It doesn't go in the patient's, it's not part of the patient's record, it's more for the agency to track. You, always less is more when you're writing these kinds of things. It's, just the facts. It's very objective, what happened, how it happened. We're always going to notify, in truth, we're gonna notify the patient. Don't you think if you were the patient in the bed and somebody made a mistake on you, don't you think you'd have a right to know? And people trust us, the public trusts us because we have integrity. We're honest, we're truthful. So don't hide something from a patient. That's never gonna have a good outcome. So we're honest with the patient.
Do you tell them first, or do you return first, and then you look at the provider, and then you look at the patient, and you look at
You can, particularly if you've never had a med error, you can go to your charge nurse first because they're probably more seasoned, and they can go with you to tell the patient. That's tough news to deliver, right? Then you notify the healthcare provider. Because, yeah,
But you want to make sure the patient's okay first before you talk to your charge nurse?
I'm sorry, say
You want to
again?
make sure that the patient is like stable in case like, depending on what kind of med it was.
Correct.
Make sure the patient's okay.
Yeah, you're not gonna leave the patient if they're unstable, yeah, yeah. So the healthcare provider is notified because we may need further orders in terms of keeping that patient safe. So when we do an incident report, it's really to verify what we did to keep the patient safe. It's our response, like it happened, now it happened, and this is what we did to make sure that the patient doesn't suffer more as a result of the error. The incident report will go to the risk managers department, quality improvement departments will look at it too. And what they're looking for is a tracking tool in some ways, right? So what they're looking for is themes and patterns. If there's more falls, if there's more med errors, why? Is it on a particular unit? Is staffing an issue? Is equipment an issue? Is competency an issue? Like what's the problem? What's going on here? And then develop a plan to fix it. All right, so again, you're going to notify, if the patient's stable, you're going to notify the patient. With your charge nurse, you're going to notify the healthcare provider. You're then going to document. You don't do the incident report before you've spoken to the healthcare provider because part of the report is what you did in response. And you're not going to know that until you talk to the healthcare provider. Okay, so who do med error reports have to go to? It's the U.S. Food and Drug Administration. They oversee all healthcare throughout the country, and they too are looking for patterns and problems. There's a Med Watch that looks, there's safety information about adverse event reporting that provides us with clinical information on safety issues. So we do document in the patient's medical record, but the incident report isn't part of that record. Again, that goes to a department for tracking services. But what we document in the patient's record is, again, just factually, as few words as you can use, what happened, how it happened, but most importantly, what we did to reduce further harm to the patient, right? What we did to keep that patient safe. So the incident report verifies patient safety. Your note in your documentation does it as well. If you've never done this kind of note, and this is you're concerned about a liability or placing yourself in harm's way in terms of your license, sit down with the seasoned nurse and say, can you just help me work through how I should say this? I just don't want to, I've never written a note like this before. I want to be sure that I'm not saying too much or too little. Sentinel events, as we've said repeatedly, require immediate investigation and response.
So you make a note stating that there was an error made, but the actual incident report doesn't reflect in the chart.
It does not get filed in the
Alright, so
chart.
I'm just
It's a tracking tool, correct. And we don't even refer to the incident report in our note. Because then the lawyers,
Right. Okay, thank you.
Yep. All right, So, this is just nursing process to prevent errors. I need to explain that to you. Staffing practices, a real concern if you step out into practice. We do have some unsafe ratios. Nurses, for instance, in ICU should have 1 to 2 patients. They should never be tripled. And for those of you who have friends that work in ICU, they're gonna say to you, oh, we're tripled all the time. But it should not be. So ratios really do adversely affect safety of patients. Resource utilization, reducing costs while maintaining and improving our quality of care. People above us that make a lot more money than us help us with that. Resource utilization. This blame-free environment. So when I began my nursing career 37 years ago, nurses were disciplined. If an error was made, innocent as it may have been, nurses were automatically disciplined. It was a very punitive environment. Nurses were in some cases fired. That is no longer the case. It's taken many years to build what we call this blame-free environment. Because if people feel like they're going to be disciplined, then they're less likely to report a mistake that they made. And if a nurse doesn't report a mistake made, the patient has no chance, right? Nothing's going to happen, no safety, no one's going to monitor that patient more closely because no one knows about the error. So the safety of the patient is going to suffer, the safety of our hospital is going to be jeopardized. So what gets in the way of a blame-free environment, unfortunately, is this rash of nurses who have been criminally charged because of errors that they made. And that is going to have an impact on nurses. Nurses will be a little more reluctant to report their errors because they fear some sort of a criminal charge being brought against them. We do record even near misses. An example of a near miss is, you go into the Acudose or the Pyxis, and you open the drawer, you do all your checks, you open the drawer, but the wrong medication is in the drawer, or the wrong dose, it's the right med but the wrong dose. Again, that's a stop the assembly line situation. We don't go any further. We immediately report the near miss to our charge nurse and to pharmacy because that can result in medication error. Even though you didn't take the wrong med, you didn't give it, that's what's called a near miss. No harm was done, but you made sure by following up with the pharmacy, because what's pharmacy going to do once you call them? They're going to do a root cause analysis. They're going to say what happened in our processes that ended up having the wrong med in that drawer, in that little cupboard. Okay?
And more importantly, they're gonna fix it so the next person doesn't.
God willing, they're going to fix it so the next person doesn't make a mistake that shouldn't be made. So the just culture, what we mean by just culture is balancing this, making people feel comfortable with admitting their responses. I'm Catholic, so the Catholic guilt would kill me. I could never not say if I did something wrong. But balancing that with, is it a competency issue? I mean, if you're a nurse who's making a medication error every single day, don't you think you should have some accountability there, right? Something's wrong with that picture. But it's sort of balancing that. But, I would say almost every nurse has made a medication error in their practice. And when it happens, the nurse needs to be debriefed. The nurse needs support because they are mortified. It's demoralizing when even if the patient wasn't harmed in the end, the fact that you knew you could have hurt somebody is devastating to you. It's not why you all came here. You came here to help people, not hurt them. Nobody walks into our hospital thinking we're going to kill them, right? Nobody comes in with that on their radar. So it's devastating for nurses. You do need to be debriefed. I was reading a case law study in grad school. We had to take a quality improvement course, and we had to read all of these cases, all of this case law. And one of the case laws was on a pediatric nurse. She had 25 years of experience. She was beloved by her colleagues, her managers, her peers, her patients, their families, loved her. She was good at what she did. She was competent. She was on her game. But guess what? She's human. To err is human. She made a mistake, and it resulted in harm to a child. And she was so distressed that she committed suicide. And so So it's really important if it happens, and I don't care how strong you think you are, if something happens to you, talk to somebody. Every agency has confidential counseling that's free to you as an employee. Please, please, I beg of you, debrief it, talk it out, talk it through. So quality improvement, even as nursing students, you're going to be involved. You don't even know it, but you're already involved with quality improvement because you're already consistent. In fact, you're probably better than anybody on the team about phoning in and out of your patient rooms, right? You're very fastidious about that because you understand that lack of good hand washing leads to patient death from infection. You get that. We talked about bundles with the CVAC. Chris Kelly talked about the bundles we have in place to prevent bloodstream infections for people with central lines. I talked about the bundle, the evidence-based bundle that's in place for people with ventilator-associated pneumonias. It's always, it's always based in evidence and research, but we're always focusing on keeping patients safe and preventing errors. It's a full-time job, I tell you. But you're already doing it. You're already participating actively in quality improvement practices. When you get out as a new nurse, you'll continue exactly what you're doing now in terms of your participation. You don't necessarily have to get down into the weeds of quality. You're not working in the quality improvement office, but even as a new nurse, you participate actively in practices that improve quality of care that we give in our agencies. So implementing new protocols, the most important step is educating nurses because JACO, the first thing they're going to say to us is, so how do I know you taught your nurses how to use this piece of equipment? How do I know that your nurses were ever trained to take care of a patient with a CBI? How do I know they know how to keep an airway patent in somebody with a trach? So a lot of hospitals do competency testing through their Department of Ed. We always have to provide that evidence should something bad happen to JACO. Right? So if the standards are not met, we keep continuing the quality improvement process until we, have an environment that is safe for patients. Total quality management is just quality and productivity is improved by using data and statistics. We look at the data, but what's the numbers really telling us? What's it revealing? It involves teamwork, so we're working very closely with all members of the team to ensure our customers, which are our patients, again, are getting high-level care. Cross off the 6 Sigma bullet on the bottom. That's deeper in the weeds than you need to go. So continuous quality improvement is a deliberate process for monitoring our quality, the level of quality that quality care that patients are receiving in our agencies. And we're using quantitative data. You see it, they have big whiteboards in the same areas. The data is available to any of us on the unit, so we can look up and see how many falls there's been. Griffin Hospital puts it on their webpage, how many patient falls they've had in the last, week or month. No one's trying to hide anything. So the Plan, Do, Act cycle, this is planning, so we plan to carry out a cycle, like in the case of Waterbury Hospital where there was a suicide. So JACO said, all right, what's your plan? What are you gonna do? And so they had to put their heads together. They did get the gift of time. They had like 6 months to pull together the research and determine what plan they were gonna do to make sure it never happened again. Then they had to actually carry out that plan, so they had to train their staff. Unfortunately, you have to prove that you've trained your staff to JACO because someone died. The study, we analyzed the data and compare results to make sure what we did worked. And then in terms of the action, what changes were made and did they work or not? All right, so I'm going to talk just in our final few minutes together. I want to just talk with you about the quality improvement project. So you will work with your clinical group and your clinical instructor. And this is in the graded assignments tab in the left-hand column in Blackboard. There's 3 documents. There's one Word document that explains it step by step and the due dates. There's another one, looks like this, it's the National Patient Safety Goals. And then there's a third one that looks like this, it's the rubric. And so what you're gonna do is you're gonna use the National Patient Safety Goals. We're gonna give you some time next week to meet as a group and work on this. But you're gonna go to your National Patient Safety Goals, you're gonna pick a topic, pick one that's interesting to you, or one that you see as a problem on your unit. So if you're on telemetry at Waterbury Hospital, maybe you see this issue of alarm fatigue, where nurses aren't paying attention to alarms. That is a thing, alarm fatigue. Maybe that's something you guys want to look at. But whatever it is, it needs to be interesting to you. So pick your topic, have consensus in your group. It is a group grade. The first part of the process, and I know it's coming up quick, again, we're going to give you some time next week. First part of it is due October 13th, which is a Thursday by midnight. And all you have to do is give your clinical instructor a one paragraph that states what your topic is for the group, what your topic is, and why you feel it's important for you to look at it. And then just list your group members. That's it. It doesn't need to be referenced. It doesn't need to be in APA format. It's one paragraph. So next week when you meet with your groups, decide who's going to actually type the paragraph. Everybody has skin in the game. You all can contribute, but one person's got to actually get it up to the instructor. So that's not so bad, right? Okay. The next piece of the puzzle is November 3rd, you're going to investigate and identify a policy or procedure. You're going to find where it's located in your hospital. You're going to pull it, and you're going to get that to us as well. You have to ask your instructor how they want it. Do you want a hard copy? Do you want it electronically? Work that out with your instructor. If you can't find a policy or procedure, again, ask your instructor how you locate it. We are working collaboratively with you on this. Then you're going to play the secret shoppers. You are going to watch, like if you pick hand hygiene, you are going to secretly watch all of the staff and see if they're foaming in and flowing out. I know. Hey, we're watching us, so. And then I just want to be, because people get mixed up about this, but each group, we used to have every student interview one RN on the unit and ask some questions about how they're following the protocol, but it's just too overwhelming for the staff. So I'm going to ask as a group, when you meet next week, just come up with a list of questions you want to ask the staff about how they're following the protocol, and then pick one person to pick one nurse on the unit to ask the questions of, okay? Just so we don't overwhelm the staff. And then you're just going to identify barriers as to why the protocol may not be followed and or specific measures that do help the protocol be followed. November 17th, you're going to submit, again, a one paragraph. You're going to pull an evidence-based article. Our library is excellent about helping you navigate the databases here. And you can work remotely. You can do it from home, and there's a chat feature right in our library that'll help you find an article. We would prefer it to be in the last 5 years. We would prefer it from an American journal, and there's filters you can put in to do that. And it should be peer-reviewed as well. Okay? So you pull the article. If you're not sure about an article, send it to me. Say, Eileen, I pulled this article. It's really good. I like it. It's in the last 5 years. It's an American journal. I just don't know if it's peer-reviewed. Well, again, we're working collaboratively together through this whole process. So then you pull the article, you're going to write one paragraph. Each student in the group writes one paragraph that summarizes the article. And you could be honest with me, I'm going to read the article. So if the article wasn't helpful to you and it wasn't going to change your nursing practice, tell me that. I'm going to know it when I read it anyhow. It's okay. This is not a reflection of you. It's a reflection of your ability to analyze something you're reading, right? If the goal is being met. So this, we do ask on this that you provide a separate, so you have your paragraph, your summary, a separate piece of paper. On the top of that paper in the center, write references, a reference, and then cite the article in APA format. And it doesn't have to be, I mean, if two of you in a group, I've been doing this for years, if two of you in a group pick the same article, it's okay. I mean, that's fine. I just want you to get familiar with the research. I don't want to read seven the same article, but.
Yeah.
And then this all culminates, almost here, guys, this culminates in a presentation here on campus. It's your last week of Plenibos. I don't think we're going to be at the hospital at all that last week. I'm pretty sure we're coming here for the presentations. We're going to do our summative evaluations, and I think we might have a behavioral health lab that week too. But, so we're going to come here, and every patient, every student in the group is going to talk. So the presentation, even if it's 30 minutes, you're talking for what, 4 or 5 minutes? And I know it's a long 4 or 5 minutes. I know people hate talking in front of groups. I don't care if you sit down, if that makes you feel, calmer. Sit down and do the presentation. I don't care about that. I don't think anybody cares about that. You'll be up there with your entire group. You're not going to be up there alone.
Oh, it's not one person from each one speak, everyone will speak?
Each person in the group has to speak. Everyone has to participate. So however you want to divide that out is up to you. But we have to hear from every student in the group.
Is it like, can I like bring a flashcard and like I have like notes I want to like refer?
Yeah,
Okay.
absolutely. And yeah, however you want to do it. You don't have to do a PowerPoint. You can, you have some flexibility. So for each step of the process, we're almost there, guys. For each step of the process, go to your rubric, and the rubric is going to tell you exactly what is required. And the good news is, if you get an A or better, you're going to get 3 additional points on your final exam. Not your final grade, but your final exam, and it does make a difference. So that's the good news. That's the good news. Okay, absolutely. Speaking of exams, I hope the grades will be coming out within the hour. And I want to talk to you about the exam question because I did get several questions on it. And I know you all know which one it is. Even though you're not supposed to discuss exam questions, I know you all know which one it is. It's the COPD. It was not intended to trick anyone or deceive anyone. I just want you to be straight on why it was what it was. So those who answered it correctly, as far as asthma coming under that umbrella, are correct. For those of you who didn't pick asthma, because it wasn't clear in the slide said risk factor as opposed to comorbid or under the umbrella, you did get credit for that. Okay? So in fairness to you, but I want you to understand that somebody with asthma over time can have airway remodeling, which is going to obstruct their airflow through their airways, and that's what chronic COPD is. It's a chronic exacerbation remission, which asthma is. It's obstructed airflow. So when their airways remodel, they do have obstructed airflow. That is why I can find you 10 resources that put it under COPD. I can find you 10 that say no, it's not COPD. But we err on the side of the students always. So for those of you who reached out, you did so respectfully. Some of you did research, showed me the articles. I think that's fantastic. As an educator, that's what I want to do. So I have no problem with that. Thank you for being respectful. Grades should be out within the hour. Okay?